So without further hesitation, I'd like to introduce you to our host for this lunchtime, Martin Lever. Martin.
Thank you, Mark. Good afternoon, everyone. We're very pleased that you are joining us today. Um, I'm Martin Lever. I work for ABL Health, and I'm the joint lead convener of the SCAR conference. I'm very pleased today to be able to introduce a good friend of ours, Louise Ross, who is a clinical consultant with NCSCT and the Stop Smoking lead for Smoke-Free Digital. I'm also very pleased to welcome my work wife, Heidi Croucher. Heidi will introduce herself, and we're the joint lead conveners of the SCAR conference. And I'm also very pleased to welcome Kevin Smith, who I've known for a few years now, and I'm pleased to see that Kevin's doing really well in his role as a harm reduction practitioner with Dorset Healthcare. So I'm going to share the slides now. Just to let you know, SCAR conference is on the 15th of September. Our next webinar will be on the 24th of March, and we will be sending out a communication on that early next week. So enjoy the webinar, everyone, and I will hand over to Louise.
Thank you very much, and it's lovely to be here. Very, very pleased to be invited. I've been in the stop smoking world for over 20 years now, and I suppose when I was running a service I would always have a CO monitor in my bag. Sometimes when I wasn't even working, you never know when it will come in useful. This hour, I suppose, will be helpful to some veterans in the service, but also particularly for new tobacco dependency advisors who may not have had a chance to explore all the benefits of using carbon monoxide as a hook for conversations with people who smoke. I also work for the National Centre for Smoking Cessation and Training, and in case anybody doesn't know, we've got an inquiries line, and we get a lot of inquiries about carbon monoxide monitoring. You know, what do I do when my patient has a high CO reading, but swears that they haven't smoked at all. We'll perhaps come back to that discussion later. But if you've got any questions about any aspect of smoking cessation, do use the inquiries line, and we get back to people straight away. My other role is with Smoke-Free Digital, which is a comprehensive stop smoking service delivered digitally. And the good news was this month we started to be able to deliver the prescription-only medications, varenicline and cytisinicline. So we've been very busy with that. Next slide, please, Martin. Super. So carbon monoxide, what is it? It's not CO2, and this is something that I impress upon new tobacco dependency advisors and some people in the field who perhaps haven't actually distinguished between what is CO and what is CO2. You quite often get people talking about CO2. Because they haven't actually realised that there's this distinction between the two. CO2, carbon dioxide, is what is in the ambient air. We're breathing it all the time. Carbon monoxide is a toxic gas, and it's the byproduct of smoking a cigarette and other combustible substances. It has a very, very prime place in stop smoking interventions because it's a measurement of people's well-being or lack of well-being that they can relate to. When we talk about the harms of smoking, sometimes it feels a little distant, a little remote, but when you actually test somebody's carbon monoxide levels, they can see that that's about them. This is real-time testing of how well or unwell they are. Next slide, please. So a bit more detail here. It is a poisonous gas. It's the same gas that, you know, you see the really sad headlines occasionally, you know, a holiday apartment has been the cause of the death of the occupants because the carbon monoxide from the boiler, the heater, or whatever has you know been issuing during the night, and people have died from it. And we know that the more carbon monoxide people are inhaling through their smoked cigarette, the poorlier they will be, because it makes their blood thicker and stickier and more likely to clot. And that line, when you're doing community interventions, is worth really rehearsing and repeating to people. When you're getting them to do their carbon monoxide reading, use those words. The gas that I'm testing for makes your blood thicker and stickier and more likely to clot, because you're painting a picture here to the people that you're trying to get the message across that smoking is harmful for their health. And some people may not understand all the biology of you know, what smoking does to you, but that image of blood getting thicker and stickier and clotting is something that captures the imagination. And what actually happens in the circulatory system is that the carbon monoxide is binding with the red blood cells. So when you breathe in oxygen, that binds with the red blood cells, and it takes oxygen to every part of your body. But when you're smoking, that carbon monoxide binds more easily with the red blood cells, so the oxygen can't be taken up by the red blood cells. So you get carbo. Martin would be able to say this. I'm not even going to do it because it's a long word.
Carboxyhemoglobin.
Hemoglobin. Thank you, Heidi. Just having a senior moment there. So yes, you've got carbon monoxide bound with the red blood cells, and that is keeping the oxygen out. So the body isn't getting all the oxygen that people need for good health, for good functioning. The test itself can be a really good way of detecting whether somebody has smoked or not, but it's even more valuable in the way of motivating somebody, because you start off at the beginning of somebody's journey towards smoke-free with you know, a higher than normal reading. And you know, it might be 20, 30, 40 parts per million. I've done tests on people who blew 80 parts per million, and that was somebody in a mental health unit who was just smoking every moment of the waking day, and waking up at night and smoking as well. And every week when they come back to see you, they can see that their CO reading has dropped, and the excitement that you can share with them is palpable. It's really important that you know, you can celebrate with them that they've gone down from 34 parts per million, you know, down to 8, and then 4, and maybe even 0. Getting down to 0 may not be possible if somebody lives in a very built-up area, breathes in a lot of you know, traffic fumes and so on. They may, or if they live with other people who smoke, their reading may never drop down to an actual 0, but it will certainly drop as they stop smoking. Smoking is the biggest reason for a high CO reading, and you know, I've finished this particular slide with the invitation to paint a picture for your client. Get them to realise what this poisonous gas is doing to them, because it gives them the motivation to actually put the cigarette aside and start breathing in clear air, clean air, oxygen, you know, what they actually need to stay alive. I can see questions popping up. We'll deal with the questions at the end if that's all right, because I'm sure, you know, the other speakers will also have questions to answer. Next slide, please. So there may be times as a tobacco dependency advisor, where you don't actually have your monitor with you. You wish you could have pulled it out to actually demonstrate to somebody. It could be that you've just happened to have a brief conversation with somebody who says, well, yeah, I do smoke and I wish I didn't. You can still use what you would be seeing in the intervention if you had your monitor with you, by simply describing it. And I've done this a number of times. Once you get familiar with the readings and you can learn to predict how many cigarettes people have smoked that day, you can ask them, estimate what their CO would be at that particular time of day, and then explain how it's affecting them. So, say 11 o'clock in the morning, you can say, well, how many cigarettes would you normally have smoked by now? And they say, I don't know, probably about 6, 7, something like that. And once you've got the experience, you can confidently say, I would assume that about now your CO parts per million would be about 17. Now that's already starting to thicken your blood, to increase your risk of clots. And so even without the monitor, you're using the technology and your descriptive powers to get them to understand what that CO is doing to them. Next slide, please. Shisha in some areas of the country will come up regularly. I live in Leicester. We see a lot of people using shisha. There'll be many other parts of the country, and people listening in who are very aware of shisha use and what that does. Now, people who use shisha regularly, or even for if it's irregular but for an extended period of time, will have very high CO readings. I've done readings on a Monday morning with people who were using shisha on a Saturday night, and their CO levels were phenomenally high. I'm talking about 50, 60 parts per million, because it is they inhaled so much smoke from the shisha pipe that their body hasn't excreted it. And it can be quite motivational for people who use shisha but don't regard themselves as smokers. They think cigarettes are the harmful thing. They're not aware that shisha is actually causing similar harms. But in fact, the more shisha is used, the more likely it is that they will suffer the same harms as a really, really heavy smoker. And it's not the tobacco. So if they say, well, I don't even use tobacco in my shisha pipe, I just use a herbal mixture. It's nothing to do with the tobacco. It's that little lump of charcoal in the bottom of a shisha pipe that emits the smoke. That's what is being inhaled, and it's harmful for the user, for people who might be sitting around breathing in the smoke, particularly if it's dialer shisha used at home, where there are maybe pregnant women, small children, babies in the same room. They will all be breathing in that smoke and having a higher than desirable CO level. Next slide, please. Cannabis is the other issue in terms of very high CO levels, and whether it's used in a spliff or through a bong, you're going to get volumes of smoke, and this will lead to high CO levels. I would refer you to the NCSCT guide for helping people who use cannabis and want to stop smoking. The guide has advice about other ways that cannabis can be consumed. It also has advice for people who want to stop their smoking and their cannabis as well. And I'll just mention as well that if you're doing CO readings, say at a community engagement event, a brief intervention session, if you're doing it during Ramadan, you're going to have possibly people who are observing Ramadan and don't want to put the mouthpiece of the the monitor in their mouths, and to avoid the sensitivities around that, because they're not actually eating anything, but some people, especially Muslim women, will have an aversion to putting something like the CO mouthpiece in their mouth. Probably best not to do those sort of brief intervention sessions during Ramadan. It may be it may lead to awkwardness and sensitivity. So next slide, please. So my final slide in conclusion, carbon monoxide monitoring, highly effective in the way of motivating people to think about stopping smoking, because they can understand that what they're smoking is having a direct effect on every organ of their body because of the blood circulation and the fact that it's taking insufficient oxygen around their body, and the carbon monoxide itself is causing harm. It personalised the message, so you can give them their actual real-time results, and if they come back to see you another day, it will be different. Hopefully it'll be lower, and they can see that they're actually making a difference to their own health. It can be a very effective call to action if you're doing a session. If you have a big banner saying free carbon monoxide testing, we can test you on the spot, and you tend to have people queuing up, particularly people who may have stopped smoking beforehand and want to just make sure that they're clear. They're usually very, very proud to blow a 0 or a 1 or a 2 perhaps, and you can say, how many were you smoking at the time? 20 a day. Well, by this time, 4 o'clock, I'd have expected your CO level to be, at least 18, possibly even higher, that sort of thing. And my colleague Mary Yates, who I'm sure some of you will know, always emphasises that GP practices, that at least one practitioner in the practice should have a carbon monoxide monitor, because every time somebody comes in for whatever the issue is that they present for with an appointment, if they smoke and you are able to do their carbon monoxide reading and show them, even if they hadn't thought about stopping smoking, being able to blow into that monitor and see that they are carrying a significant carbon monoxide load could be the turning point where they decide to give stop smoking a go. Thank you very much.
Thank you, Louise. Hello, everybody. It is wonderful to see so many names I recognise in the participant list. We've got nearly 500 people on this call today, and I think another 200 or so have signed up that will be watching this on demand. So brilliant you're here to share the next half an hour or so with us. Those of you that don't know me, my name is Heidi, and I do wear a few hats. I believe now one of them is Martin's work wife. So I founded SCAR 6 years ago now, because I felt there was a gap in a gap for us all as stop smoking practitioners to come together and to meet one another and to share learns and experiences and to hear the latest current stuff that's happening. And then a few years ago, Martin joined me as my co-partner with SCAR. So that's one of my hats, and that's my hat today. But I also wear a couple more hats. So I lead the smoke-free work, some of the smoke-free work in Dorset, and I certainly led the implementation of the long-term plan piece, which I'm going to come on to shortly. My background is midwifery. I've been a midwife for nearly 30 years now and worked as a smoking and pregnancy midwife for many, many, many years. And that's really where my journey started in this world. Please can you all complete the poll question that we put at the start of this chat? And also just another quick reminder before I move on to my slides, that any questions for the speakers today, please pop them in the Q&A function, not the chat function. So for those of you who are new to smoking cessation or new treating tobacco dependence advisors, I just want to share with you a really good document that was published and released just over a year ago. And also this is a reminder for those of you that may have seen it. So as part of the long-term plan work, NHS England commissioned the NCSUT to write a new standard of care for inpatients. We were doing all this work where we were implementing the long-term plan pathways within the acute hospitals and also the mental health inpatient hospitals, but we didn't have a standard treatment plan for practice. And that's where this came in. So it's a great piece of work, and I'm going to share the link as I come towards the end of my presentation, but it's just to say that treating tobacco dependence should no longer be seen as a lifestyle choice. It's an illness, it's a disease, and if we look after people in the inpatient setting who smoke, we can have such substantial positive benefits, both on them as an individual, but also on our healthcare service. Thank you, Martin. Next slide. So this should be seen as a clinical priority in the inpatient setting, and it should be treated like we would treat any other life-threatening treatable disease. And the standard treatment plan talks about diagnosis, so how to identify that somebody smokes when they come into hospital, that it's really important to initiate treatment to help with nicotine withdrawal symptoms as soon as possible. And in the mental health setting, we say within 30 minutes. You should be supporting somebody so that they don't go into nicotine withdrawal, and as soon as possible in the acute inpatient setting, half an hour to 2 hours, we really want that person to feel comfortable. This plan talks about behaviour change and how the tobacco dependence advisors come in and have that really beautiful conversation at the bedside and make sure that follow-up is in place on discharge and to adjust the treatment plan at any stage of that pathway. Next slide, Martin. So these are what the documents look like. We've got one for the acute inpatient setting and another one for the mental health inpatient setting. And each standard treatment plan is broken down into 3 parts, 3 bundles. So the admission bundle is for the admitting ward teams, where they identify that somebody smokes on admission. They give that very brief advice. They initiate nicotine replacement therapy or e-cigarettes, and obviously we've now got our partial agonists, cytisinicline and varenicline, and they make that opt-out referral to the in-house tobacco dependence team. Then that moves us through to the admission part of the bundle, which is the inpatient bit, where the tobacco dependence team come and do that beautiful conversation at the bedside, giving that intensive behavioural support, readjusting medication if necessary, if it isn't quite the right medication or the right dose for that person, making an individualised treatment plan that can be adapted and flexible at any point of their inpatient journey. And then that moves to the post-discharge bundle, which is where the in-house tobacco dependence team make sure that follow-up is in place for anybody that wants to quit smoking. So those that start their quit journey in hospital that want to continue it once they're discharged, they make sure that the patient leaves with the stop smoking medication that they're started on in hospital, and that there is a referral through to the local stop smoking service so that the smoke-free journey can continue once they're discharged and they go back to the place where they live in the community. Thanks, Martin. Next slide. So I just really want to home in on carbon monoxide monitoring because that's the content of this webinar. And it is gold standard that as part of our new standard treatment plan in the hospital setting, we offer carbon monoxide monitoring, both on admission. So there is an expectation as gold standard practice that when a person is admitted to hospital, the admitting ward team carry out the carbon monoxide test. And then this carbon monoxide test is followed up when the in-house tobacco dependence team go and see that person. And like Louise said, when somebody starts a smoke-free journey, it's great for them to see the reading come down. And that's what would happen on admission. They'll blow a certain reading. They're now in a smoke-free environment, on stop smoking medications, not smoking, and they'll see their reading come down. Thanks, Martin. Next slide. As part of the standard treatment plan, And I was part of the team that were working through this document and supporting the authors with this document. Because this was new pioneering stuff for us within secondary care, we had quite a lot of conversations around what is an okay level of CO and what isn't an okay level of CO for a person in hospital. And we certainly used the Public Health England algorithm at the time to work this through. The CO level for an inpatient is very different from a maternity one and also a community-based one. So as part of this treatment program, the cutoff is 6 parts per million. So if somebody comes in on a mission, they blow below 6, great. That's a lovely non-smoking reading. It doesn't mean to say they're not smoking, but it's a good reading. And if they blow higher, and it's around having those further conversations and maybe asking if they smoke. So Martin, if you can just move on to the next slide. As part of the standard treatment program, there's some examples of how to have that really lovely conversation with a patient when you offer them the carbon monoxide test. And I'm just going to home into the example on this slide of somebody that's blown 6 parts per million or above. Okay, so they're coming in with an abnormal CO level. And the conversation looks something like the monitor is showing a reading of, let's say, 12 parts per million, which is what we'd expect to see for someone who is still smoking. The normal range for somebody that does not smoke is between 1 and 5 parts per million. And so you can see that your reading is higher than what we would expect. The good news is that if you do not smoke at all, you can get your level down to a level of somebody that does not smoke. So have a look at these examples of how to have that really lovely conversation in a non-threatening way. Thanks, Martin. Next slide. And then alongside the standard treatment plan, those 2 documents that I showed earlier, NHS England also commissioned the NCSCT to produce these wonderful e-learning modules that are really easy to use. They're for the admitting ward teams. They're, there's the main module that takes about 30 minutes, and then there's bolt-ons. And then Martin, if you move on to the next slide, there's an example of the carbon monoxide monitoring bolt-on that can be done as part of this e-learning. And that talks about an overview of what is carbon monoxide, how to do the test, and how to interpret those results to the person who you've done that test on. So please do share these e-learning modules with your admitting ward teams, particularly so that they can learn how to do this. Thanks, Martin. Next slide. And then I just really want to home in away from the national picture and to look at the local picture in Dorset. So I led the implementation of the long-term plan work, and I think I took that role on as soon as the long-term plan was launched, so back in sort of 2019, 18, 19, I think it was. And at that time, I felt it was really important that we got it right on admission. We had an IT system available for the admitting ward teams to carry out a good smoking assessment of somebody. It's called electronic nursing assessment, ENA. I'm going to call it ENA for short. It's a bespoke development package for a hospital in Dorset, so it's not a national package. It's something that we create in-house, and it's a single point of access for recording and storing all the nursing assessments, and the smoking assessment is one of those. It alerts clinicians to when assessments are due or when results come in abnormal, and it calculates scores and risks. So as an example of that, it will calculate the CO test. When you run through your series of Fagerstrom questions, it will then calculate for you what the Fagerstrom score is. And it can also give some guidance to clinicians if they just want a little bit more information about whatever the assessment is they're doing, or say about carbon monoxide monitoring. What is it? Where does it come? Where does CO come from? And if this assessment is completed on an iPad at the bedside. And Martin, if you move on to the next slide, when I was working with the IT team to develop this smoking assessment on admission, I felt it was really important that we offered CO monitoring as part of that assessment. This was before we had the standard treatment plan, and I guess it stemmed from my work that I'd done in smoking in pregnancy and saw the benefits of offering a CO monitor, a CO screen, a CO test before you ask the smoking question. So this is a screenshot of the E&A assessment. The first question that launches as part of this assessment on admission in the inpatient setting is the offer to do a carbon monoxide test. So it's advised that all patients admitted to hospital complete a carbon monoxide test. Would the patient like to do this now? And the little I button is a little bit more information on what is CA. When we started to roll out this on the pilot site, which was the acute medical unit, we quickly realised that actually not all people are well enough to do a CO test on admission. So we added that in as an option. And we also realised very quickly that carbon monoxide monitors go missing, they won't walkabouts, and they needed to be replaced. So we also had to add in the option that actually there isn't a CO machine available at this time. And as we rolled out across all the admitting wards, we knew it was important to give them quite a few machines. And I think each ward had around between 5 and 7 CO machines so that they could find one to do the test. Thanks, Martin. Next slide. And then obviously the patient blows into the machine, they get their reading, and the next part of this IT assessment is a slider. So the person conducting the test can move the slider up and down to the level. So as an example, this is a CO level of 7 on this person. Thanks, Martin. And then we move into the smoking question. So we felt it was really important that we offer CO testing to everybody in a non-judgmental way before we then go on to say, I can see that your carbon monoxide level is high. We've already said it comes from this source, but more commonly cigarette smoke. Can I just ask, do you smoke? Regardless of the CO level, we would always ask anybody anyway if they smoke. So that's just an example of the IT system that we brought in 6 years ago in Dorset, ahead of the long-term plan standard treatment plan. And I would encourage you all at this stage, if you don't offer carbon monoxide monitoring on admission in the inpatient setting, then to go back and have those conversations, because it really is gold standard and does make a difference. And I'm now going to hand you over to my lovely colleague, Kevin. And I said I've had the pleasure of working with Kevin for a number of years. His background's respiratory. He's worked as a TDA in the acute general setting, and then more recently in the last year or so in the mental health inpatient.
Hello, everybody. Good afternoon. As Heidi's just mentioned, I started work for the NHS at Dorset County Hospital in 2018 and worked for 6 years in the respiratory ward there all the way through COVID. And at the end of COVID, a position became available to help set up the tobacco dependency service in Dorset County Hospital, which I jumped at the chance to do, having seen the damage that smoking caused to people in the respiratory ward. The benefit of working in an acute hospital is many of the reasons that people are actually in hospital are caused by smoking. And they're often whipping out for a cigarette with a chest drain attached, or a catheter, or a drip, which it's not good luck. But and once you get into conversation with people and they agree to have a carbon monoxide test, you can see the difference that makes. It's such a motivational tool to help somebody to stop smoking. And in acute setting, we were only able to use NRT, but to help them to stop smoking. But you could see when the next time you visited them and the levels had reduced, the massive effect it had, and the motivational effect of using carbon monoxide testing. It was fully embedded, and a role came up with Dorset Healthcare, again setting it up from nothing. And we now work with mental health inpatients in Dorset Healthcare. The important thing that we do is we have nicotine and vapes available out of hours, so that if somebody is admitted, they can get treatment straight away for withdrawal. And that's the first thing staff do now when they are admitted, is offer them NRT or vapes, which means that by the time we get to see them, usually they've been started on the vapes, and we start the conversations. Quite often, especially in the mental health inpatient setting, the patients, they're not really well enough to get into a conversation, and you can't really have one-to-one conversations with patients like that. So we hold coffee mornings, and what we do at the coffee mornings, we use our carbon monoxide tester, and we have a bit of fun with it. We carbon monoxide test staff, we carbon monoxide test patients, and we have a little bit of banter. Without putting the patients under any pressure, we'll say, how long have you been smoking and how many cigarettes a day do you smoke? And then they'll do a carbon monoxide test, and then it's flashing and going and saying, oh my goodness, I say, is that high reading? Yes, you've blown an 18. Normal reading is less than 6. If somebody blows less than 6, I don't say that means you're a non-smoker. I just say, on this occasion, you've blown a normal reading, because they might have had a cigarette yesterday, for all I know. But the next time, we then encourage them to go out and vape when they're going out instead of taking a cigarette. So every other time they'll vape, and eventually it gets to a stage with the patient where, because carbon monoxide readings are coming in, they'll go out and have a cigarette and they'll say, hey, I had a cigarette this morning, I don't even like the taste of it. And that's because the sense of taste and the sense of smell is recovered. And at that point, that's a good change talk. And we ask them to make a quit attempt, and they set a quit date, and lo and behold, before long, they're blowing a normal reading. Our journey continued because now we work in the community, and exactly the same thing. Now I do a clozapine clinic 1 day a week, and we've got continuity of care from hospital to community and vice versa. And we use a carbon monoxide test in exactly the same way. And again, it's a massively motivational tool. Last week, one of my patients blew a 27. He's cut down the amount he's smoking, and this week he blew a 7. So, you know, that and that really motivated him. I can tell you, you know, it's a fantastic thing. I think the thing to do now is let me show you a carbon monoxide test. So I don't know if you're all familiar with the Pico tester. Basically, it's got a little plug-in bit there, and each time we give the patient a new mouthpiece, we turn it on. It takes a few seconds to load, and I usually talk the patient through what I'm going to do. I usually say, in a minute, I'm going to ask you to breathe out and into your lungs, take a deep breath in and hold it, and then it'll count down 15 seconds, and then at the end of the 15 seconds, I want you to blow into the tube. It'll beep 3 times, and then blow into the tube for as long as you can, without passing out. I had one patient that did pass out. Anyway, so here we go. I'm going to do it on myself. So there's a little arrow, so I'm breathing out. That'll do for me. So well done, Kevin. You've blown a 3. I don't know if you can see that. So that's a normal reading. I always say that's a normal reading. What I don't do is say that means you're a non-smoker, because it might not. So always use that terminology. You've blown a normal reading. And that's me. So thank you.
Thanks, Kevin. That was really helpful. We'll go back to the slides. We're on the left side. Mark, are we handing back to you now?
Yes, if I just have a quick couple of minutes, if that's okay, and then
okay. Before you do that, can I just thank Livio and Joanna from Intermedical for they've worked really hard behind the scenes on this webinar. So thank you to both of them and to Mark. And I'll hand over now back to Mark.
So yeah, it was just to give you a bit of information about the remote CO monitor that we do at Intermedical. So Kevin obviously showed you the Pico device, and if you're aware of all the CO monitors, there are 3 different Pico devices. So there's the Pico Baby, which is used for maternity, and the Micro, which does everything. So there are those three devices, but we also do a remote device, and that's this one here called the ICO Quit. So it comes in a very, very small box. And this device hasn't got a screen on it or anything like that. Everything that's recorded on here is recorded on an app on the patient's phone. So rather than obviously just doing the test and the result appearing on the device, it's all done through the app on the phone. Now, there are two apps available, and I'll show you both of those. You can hopefully, ooh, yeah, it's not very great there, but maybe you can see them there. So there's a blue app there and oh, that's better. Oops, a blue app and a pink app. So there's my pink app. That's my Pico Baby app. But if I show you the blue app, when you open it up, it's probably not going to show up very easily on the screen, is it? Because it's got a bit of glare. Oh, there we go. Oh, no, not too easy. But when you open up the app, it'll ask you just to sign in. And when you first open the app, it'll ask you to register your details. So you put your name, your age, your smoking history, all that sort of stuff. But every other time, it will just ask you to log in. So you just log in with a password. So I'll just type mine in quickly. And once that has logged in, it brings up your sort of home screen. This is probably not going to show up very well on here, but I'm just trying to see if I can stop any glare appearing. Yeah, it's not really going to show. So on the main screen here, it's just showing you my last recording, which was 1 part per million. But I do have a number of options that I've got at the bottom here. I can look at a series of results that I've done in the past. So it will show you a trend of results over a period of time. So if they've been a smoker and their first reading was sort of high, let's say it was 30, and then they stop smoking, you'll see a gradual sort of decrease in the CO reading over a period of time. So that's quite nice to have. But the other option you've got in the bottom corner here is breath test. And if I click on that, it will ask me then to turn the device on. Now, the device connects to the phone via Bluetooth. So when I press the on-off button, it will turn the device on. The Bluetooth will hopefully flash. Try again. There we go. So the Bluetooth light's turned on. The device, the app then says the device is connected successfully. And then you can go in to do a test itself. So again, we just click on the new breath test at the bottom of the screen. And exactly as Kevin described, it's just the same as doing a normal CO test, but you have a 15-second countdown appearing on the screen. So the patient can then hold their breath at that time. So when you get to 0, you then blow into the device. And then it will just take a few seconds for that to analyze on the screen. Just see when that appears. And then hopefully we'll see a result. There we go. So there's my reading, 1 part per million. And that just comes up straight away. Now, you do have the option to click on continue at the bottom. It will then come up with some information about smoking habits, how many cigarettes you've done your quit date, etc. So that's all on the screen. We can click on continue again, and then it comes up with a message, which again, you can't really see, but it comes up with a little message to tell you what your smoking status is. And then if you want to, you can send that result to a number of well, you can send it in a number of ways. You can either send it as an email, a WhatsApp message, a text message, etc. So there's a few ways you can do it. Most people tend to email them. So you click on the sort of email icon, and then you can you'll see hopefully on the screen there's your email message, and then it says my CO reading was 1 part per million, and you can just type in the clinician's email address, and then that will then get sent to the clinician. So it's a pretty straightforward device to use. It's available on iOS and Android, so you've got 2 options. Obviously, patients will have different types of phones, so it's not available on both. If you want further information on it, if you can email us at sales@intermedical.co.uk, and again we can get in touch with you that way. If you've got any support that you need for, if you're a current user of the ICO Quit, if you've got support questions, email us at support@intermedical.co.uk, and we'll be able to help you with that. But hopefully that just gives you a little insight into how the remote CO monitor works. Thank you.
Thank you, Mark. Really good to see these advances in the technology now, and I know lots of, especially community services, are doing remote consulting, so this is a real, just another tool in our armoury. We're going to move to Q&A in a minute, and we'll start to read through those that you've put in the chat, so thank you for those. If you would like a certificate of attendance from today, that's the email address. It's marketing@intermedical.co.uk, and but please do give them a couple of weeks to get that back. Our next webinar is on the 24th of March, and that's about cytosine varenicline. We've got a really extended webinar on the 24th. We will email everyone about that next week. So Q&A time. I will take my slides down, and let's have a look in Q&A. Let's have a look. How high is too high? I work in mental health, and we had 103 parts per million. When do we seek medical help? That's from Lisa. So
That one for Louise?
yeah.
Yes, I think you'd have to look at everything about what is happening with the patient. You could give simple advice that stopping smoking is really important for their health, because you're very concerned about the high levels of carbon monoxide and what the smoke, if it's a really high level, they're having like probably easily more than a pack a day. That will be having a very, very harmful effect on their body, and so you give very strongly worded advice. It depends what other symptoms they're showing. If there's breathlessness, chest pain, dizziness, pallor, the signs that somebody is quite unwell in front of your eyes, then I would say medical help might be needed at that point.
Can I just add one thing briefly as well? I had a lady who blew a 68 at Dorset County Hospital, and she hadn't smoked for a year. She'd been in overnight, and she had a faulty boiler. So I gave her the boiler line, and they condemned her boiler. Her partner and her son would have been sleeping in that flat overnight, if with that faulty boiler, so potentially they could have died. So it's possible that they've got it from other sources, not necessarily just smoking.
Okay, next one is generally support is tailored for patients who are heavy smokers with mental health conditions to be offered reduction. At what point should this support end if they feel they are likely to smoke once NRT has stopped? Good question, and I've worked a lot in mental health, and obviously Kevin's working in mental health. Slightly complicated in mental health because, first of all, we're probably offering temporary abstinence, and that's so that we can fulfill a smoke-free policy, because we don't want people smoking on site if possible. But we should stay with people as long as possible, and this is where our behavioural practice becomes really good, because it's while we build trust with a patient, and it can be in inpatient or in community mental health setting. We're building trust at the start, and we're asking people through our practice to reduce by using their meds correctly. And that's a really important message that we need to get across when we're supporting our clients, is that if people use their meds properly, they will be able to make quite significant cut downs, and it's just moving people along. And our behavioural practice, how do you feel about the progress you've made? These are really good questions. So how do you feel about taking the next step? Do you feel confident, in reducing a bit more? So it's a really nice conversation to have. And of course, people will be discharged or people will be long stayers, but it's all about that relationship. Will the NRT ever be stopped? It shouldn't be if someone's in an inpatient setting. But I think in community, we're moving towards tailoring now and staying with people and getting them over the line. And these are more extended quit dates, but that will depend on the area that you're in. But we need to spend, we're talking about inequality here. And it's inequality, I guess, really at the peak, because we know in mental health, that patient group, we're looking at 50 to 60% smoking rates. So we need to stay with them, or that equality will remain. And that's why it's remained stubbornly high. Okay, next one. Do coal fires cause high CO readings? You bet they do. And that's why social landlords are mandated to put carbon monoxide monitors in properties, because carbon monoxide is a deadly gas. So yes, absolutely, it will can cause a high CO reading, as can a faulty boiler. There are other things as well. Can you please give a breakdown of the number of cigarettes smoked equivalent to CO levels? I think that's quite difficult because that will depend on individuals. So the CO monitor is an indicator. But when you do the test, in my own practice, and I've worked in mental health, I've worked in some very challenging community settings as well, with rough sleepers, patients with serious mental illness. I mean, that's part of our practice. It's say your reading is this number. How do you feel about that? And if it's quite high, say, what do you think's caused that? And if it's low, celebrate it. Say, well done. What do you think? Why do you think your reading's so low? Let's have a look. Good one. I'm going to hand this over. I can answer it, but I want to bring Kevin in a bit. Kevin, somebody has a score of 24, but says she hadn't smoked. Not lactose intolerant or problems with her boiler. My colleague tested monitor scored 4. Can you please explain this different reading? I think it's a faulty. Kevin?
I think there is a medical condition that can cause, I can't remember what it's called now, but that can cause higher.
Sickle cell can.
That's it. Yeah, that can cause higher. So it may be that another investigation needs to be had for that. So, but it is possible. I mean, exhaust fumes. Just be careful about barbecues and don't take the baby too close to the barbecue smoke, because there's lots of things that can raise carbon monoxide levels if they've been in heavy traffic. In London, a normal reading is less than 10 on the carbon monoxide testing. So it depends where you are and the levels of pollution that there are nearby, really. So
okay, thanks, Kevin.
Can I just come in? I'm just going to say, and are they being really honest with you?
Yeah.
That's my concern there. It would be how to change that conversation around so that they feel they can be really open and honest about what's going on.
While you're there, Heidi, I've got another one for you.
Oh, thank you.
What post-discharge support from TTD should be performed, and how should this be integrated with local stop smoking services? From reading the post-discharge bundle, the expectation for TTD is to perform a 2-week and a 4-week post-quit date.
That is correct. So
Yeah.
yes. So as part of the post-discharge care bundle, there is the expectation that the in-house treating tobacco dependency team do follow your patients up once they've been discharged if they're on a quit journey. So a 2-week call and a 4-week call, just to make sure that they're using their stop smoking medications, they haven't run out of their stop smoking medications, and that they are now engaging with the local stop smoking service who you refer them to. And if they're not, re-refer. And use your motivational interviewing skills to support them with engaging. If on that follow-up call they've stopped using their medication that they went home with, again, explore with them why. What are the challenges? What's happened since they've been home? and using that behavioural support, you guide them through restarting if that's what they want to do.
Thanks, Heidi. Yeah, and something else, if trusts or TTD teams are referring to local stop smoking services, we know that what works best is a fast pick-up once people are outside. It's a really important part of that discharge process. Please can we have more training work done around smoking cessation, mental health medication? We will look at that. Clozapine, specifically referring to clozapine and olanzapine. Yeah, we know the issues associated with that and how it affects the hydrocarbons. So that's something that we can look at. Isaka, I'm wondering if you made it standard for TTD therapist advisors to have an automatic access to give care patients NRT. That's a difficult one because every area, every trust will be different and there will be local policies in place. There are examples where some areas can, the practitioners at a certain banding can provide NRT. Some trusts, it will need to get signed off by a clinical member of staff. So I'm afraid it is Isaka. I can't give you a one-size-fits-all answer for that because it's different everywhere. Nikki, we have a similar smoking assessment. However, it's not mandatory on admission. It's mandatory on discharge. I'm trying to get this amended. However, it is not deemed an IT of a priority. Heidi.
I'm going to say you're not alone, and I
Yeah.
feel your pain, and until it, I guess, becomes mandated, you know, across all trusts, it's going to be hard. I think all you can just do is keep, you know, banging on that same drum, which is it's so. How on earth are we going to ever roll out this intervention well if we're not in a position to systematically identify people electronically when they come into hospital that they smoke? And then that IT system will link in with your treating tobacco dependency service, and you're just able to engage so much better and run the service well with that in place. And if I can help in any way, please call out to me.
We are over time now. It's 2 minutes past 1. So what I'm going to suggest with the questions is, can we answer these offline, Heidi? Do you think?
I think that might be a question for intermedical.
We can answer offline. We're okay with time, so we're not going to be.
I mean, I'm happy to keep running for another few minutes if our speakers are.
I need to get off. I've got to go somewhere. So
Okay.
Okay. All right. So we'll stay on, and Heidi and the others will keep answering. Thanks everyone for joining today. I do apologise. I need to drop off, but I'm back to the day job now. So thank you all for attending, and
Good to see you, Martin.
Yeah. Thank you.
Thanks, Martin. I'm happy to keep rolling for another 2 minutes. I don't actually know where Martin got to with the questions. So bear with. A really good question that's come up around CO monitoring and vaping, Louise. I don't know if you want to come in here. So will a CO monitor pick up if someone's using an e-cigarette?
No, because there is no product of combustion in a vape. And that's why it's so much safer than smoking. Highly recommended as a quit smoking aid, and NICE approved, no CO.
Thank you. There's some questions for intermedical, which I'll let you come in around the cost of the ICO quits. Another question, Kevin and Louise, what if somebody can't hold their breath for the full 15 seconds? And I know, Kevin, you would have seen this working in respiratory.
Yeah, and I often say to them, do what you can. You know, if you can do 10 seconds.
10 seconds is fine.
And you do get quite a decent reading, even out of that. So.
Thank you both. What happens if all the readings are below? Why can't you use them to determine non-smoker? Okay, so if all the readings are coming in at below the cutoff, so 5 parts per million or less, why can't you use that to determine a non-smoker, Kevin? Do you want to come in with that one?
I think I use the terminology of a normal reading for a person. I can't use that to say they're not smoking because they might have had a fagged the day before, or over the weekend they might have had some cigarettes. So that doesn't mean they're a non-smoker. It just means at that time they've blown a normal reading. So it's just the way I word it. I mean, if you want to call them a non-smoker, then I'm sure you can. But I don't think that's a diagnosis of a non-smoker.
No.
Because we know that after 24 hours, carbon monoxide's left the body. A question for you both. Don't mind who answers it. It's around maintenance of the machine and keeping them clean. So how often do the D pieces need to be changed, and how would you clean the device between patient use?
Every month, and we've got some alcohol-free wipes that we use. I know people can use cleaner wipes, but I think they have been known to cause damage to them. Again, I think it's more important that we do clean them between use, but the mouthpieces, we usually change them beginning of every month.
Thank you. Another question, maybe this one for you, Louise, is around alcohol use. So if somebody is drinking high volumes of alcohol, would that affect their CO level? And I actually did see this in practice as a midwife. Louise, I don't know if you want to come in there.
I've not experienced that myself. So from clinical practice, I would say no, but you just never know. And there could be some secret smoking going on.
Yeah.
But, you know, CO tests don't detect alcohol use in my experience. They detect the product of combustion.
Okay, that's interesting. So, and Kevin, please chip in if you want to. So when I was a smoking and pregnancy midwife, I was looking after a person who was a smoker, but also struggling with alcohol too. And I worked with her pretty much throughout her whole pregnancy with her smoking, and her CO readings, they came down, but they never really came down to what I would say was a non-smoking reading. And we couldn't work it out. And I actually explored it further and found out that alcohol could be detected on the sensor and therefore raise the level slightly. But that might actually be a question for intermedical to come in and say, does alcohol use affect the sensors, and give you a false positive?
And I don't know the answer to that, so you're right, I think.
For what relates to we recommend the use of alcohol-free wipes for exactly the reason, because especially for very high alcohol content that could slightly affect the reading. Alcohol in breath, it really depends on the level of alcohol, but it should be minimal. It shouldn't jump like massively. But yeah, alcohol does interfere with the sensor. This is why we say to use alcohol-free wipes and not to use gel as well when they clean.
Yeah, alcohol gel. Yeah, that's another one, isn't it, that can affect it slightly. Thank you. Louise, I'm going to throw this question to you, mainly because of your experience in this. But there's a question that have we managed to achieve stop smoking policies on site? And I know, Louise, I think I'm right in saying that you were like one of the first pioneers at doing this.
To create a smoke-free policy
on site, yeah.
Well, there's a lot of backing from the Department of Health, you know, who expect sites to be smoke-free. Now, the tobacco and vapes bill could well mandate that and make it illegal to smoke on site, you know, even in the grounds. We don't know. That'll be in the detail. But in my experience, again, permitting vaping as an alternative to smoking will help compliance with a smoke-free policy. You know, there's no need to be afraid of the idea of patients using a vape. A lot of them will actually be admitted, you know, having already been vaping. And, you know, we wouldn't want a situation that I encountered back in 2016, where the patient came in as a vaper and was told she couldn't use that because it might be dangerous, but she could start smoking again. You know, we absolutely don't want that. So, yeah, allowing a harm reduction product as an alternative to smoking helps compliance.
Thank you, Louise. I'm going to answer this question quickly around the cutoff with different levels. So the level is lower for maternity, than it is for the normal inpatient setting. And the question that's come in is, would a admitting ward member of staff know that the cutoff is lower? So if the patient's admitted into the general side who's pregnant. To answer that question, we felt it was really important to embed that into the training when we did the training on CA monitoring on admission. However, I would probably say as a rule of thumb, no, they probably wouldn't know that unless you make sure that that is covered in training. And when we devised our local CO charts for the inpatient setting, we obviously had these laminated and lots of copies on each ward. We had the maternity one on the other side, so they could flip it and see what is what are the limits for pregnant people, and on the other side, what is the CO level for non-pregnant people. And then Louise, I'm not sure if or Kevin, but it's around lactose intolerance. So we know that if somebody is lactose intolerant, they're going to give us a false positive, or their CO level they below is going to be slightly higher. And there's the question is from Lisa is around why does that happen?
Gases.
Gases. Yeah. So the machine just picks up a gas in the breath. It can't distinguish really what that gas is, so that's why you'll get a false positive.
Would you say the same, Kevin?
I don't know, to be honest, but I'll accept that guesses.
Yeah, I mean, that could be a really good question actually for intermedical to answer. So if somebody's lactose intolerant, why do we get these false positive readings on a carbon monoxide machine?
It's because lactose intolerance actually produce hydrogen. Therefore, the sensor have a small cross sensitivity to hydrogen. Our monitors actually call very, very low cross sensitivity to hydrogen. But in the event that the patient is extremely high, that could potentially raise the level.
Thank you. And I'm going to call this to a close very shortly now, but it's just there was a question around the other disease that can cause a false positive, which is sickle cell, and that's more actually in the carboxyhemoglobin bloods. So if in your practice you do, and this is mainly in maternity, we're seeing this, somebody blows a high reading and are adamant they don't smoke and they haven't been around anybody that smoke, that then follow the pathway to have bloods taken to check carboxyhemoglobins in the blood. What we're seeing is sickle cell can also affect that. And I think, because a lot of these questions I'm at the bottom and they're just really a repeat of the questions that we've gone through. So I'm going to call it to a close, if that's okay.
Thank you very much to everyone for joining. If you haven't actually completed the poll, I believe most people actually have. We're going to try to go through the questions that they stayed unanswered and email you directly for those. But thank you very much. And if you have any more questions, please email sales@intermedical.co.uk, Heidi@scar.uk for SCAR-related questions. If you wish to have a attendance certificate, it's not automatically sent, so you have to email marketing@intermedical.co.uk. Thank you very much and have a lovely day, everyone. Thank you.
Thank you.
Thank you.
Bye. Bye.